everyone. Welcome to the OR Manager Conference Encore virtual event. I'm Carrie Shapiro with OR Manager, and I'm pleased to welcome you here for our live virtual session, COVID-19 and ERAS, Leveraging Enhanced Recovery Protocols During the Unknown. Throughout today's session, we encourage you to submit your questions in the Q&A chat section on your screen. At the end of today's presentation, we will open up for live audience Q&A. I'd like to take a moment and thank our sponsor, Cardinal Health, for providing our guest speaker, Dr. Keith Biermeister. Dr. Keith Biermeister is a colon and rectal surgeon with San Diego-based Scripps Health. His practice spans a wide range of colorectal disorders. He performs both screening and diagnostic colonoscopies and has been practicing medicine since 2012. Dr. Biermeister serves as the General Surgery Representative of Scripps System-Wide Robotic Surgery Joint Operating Committee and also serves as the Scripps Medical Director for the Enhanced Recovery After Surgery program. It is now my pleasure to turn it over to Dr. Biermeister to get started with today's program.
Thanks, Carrie, for that kind introduction. So we'll get into our talk now, and we're going to talk for about the next 30 to 40 minutes here about enhanced recovery after surgery, not only in the pre-COVID world, but in the post-COVID world, and how that's relevant to everything we're doing today. So just some business slides here, disclosures, conflict of interest. Cardinal does sponsor this event, and I'm on their speakers bureau, as well as Merck Pharmaceuticals. There's no relevant conflict of interest with that. So moving on to just a general outline here of the talk today. We'll start a little bit with who I am and why I'm giving this talk, I guess. Moving on to defining the problem. Oftentimes we're given these talks for a reason, and in this particular situation, I think there's a very good reason. So we want to really talk about what that issue is and why we're addressing this today. We'll talk a little bit then about what ERAS is. Historically, the history of ERAS, what defines ERAS, and then get into the defining components of ERAS and break that down into the preoperative, postoperative, and intraoperative components. And I'll give you a general overview of most things that are included in that. And then we'll get into a little deeper dive on some of those details as we move through the talk. And then finally, probably the most relevant is how this actually works in a real life situation. So how we do it at Scripps, that's my hospital. And we will give you some real life examples of how we started and where we've come from since 2017. So moving into the talk again. Who am I? My day job is I'm a practicing colon and rectal surgeon in a small private practice, myself and my partner. I'm board certified in both general and colorectal surgery. In addition, I hold some administrative roles. I'm the current general surgery section chief and have been in that role since 2016, and the chairman-elect of the Department of Surgery, which starts in 2022. I am the system-wide medical director for Enhanced Recovery After Surgery program here at Scripps, meaning I'm intimately involved with establishment of all the protocols from the inception in 2017 to our subsequent service lines that we've established since then. And we'll go into a little bit more of that when we get into our components of the talk there. And then I'm also the medical director for value analysis. So Given that ERAS really was born in colorectal surgery, I think we've had really a strong push for it here at Scripps, and our program certainly started in our colorectal patient population. But I'm also intimately aware of some of the more administrative impacts given my role in that side of things as well. So it sort of positions me well to speak about this stuff. So this is my hospital. I'm lucky enough to practice here in La Jolla, and this is our campus view from my office. And again, not a hard place to work. So we will move on to getting into kind of the meat of the talk in terms of defining the problem. So again, as I spoke about in the outline, we're talking about this for a reason. And, historically, there's always been a financial strain on the health system. And, the system as it currently exists is not the most sustainable system from a financial standpoint. And this was pre-COVID. So we cannot continue to lose money as cost of care continues to rise without striving for better outcomes. So we really need to find cost savings wherever we can. We need to start implementing things that work and stop doing things that don't. And that sounds like a pretty common sense statement, but you'd be surprised that we do certain things because we've always done them, and affecting change at that level is a lot more difficult than you might think. And we have to look for areas where we can find value that is beneficial, obviously, to the patient. That's what we're here for, but also the healthcare system as well. So let's talk about some pretty disturbing numbers. Total healthcare spending in America went over $4 trillion in 2020, and more than 30% of that, or about $1.24 trillion, was spent on healthcare services. If we look at areas where we can make a more immediate impact on that, I would say we should look at things that are preventable or reducible. And certainly, as we look at length of stay from a surgical standpoint, I think that's one of the prime areas where we can make a more immediate impact. So hospital costs averaged $2,607 per day throughout the United States, with California, which is, I mentioned previously, is where I'm from, topping out at $3,726 per day. And the Wyoming, our opposite end of the spectrum, at $1,383 per day. So, a bit of a range there, but either way, that's a pretty significant number that a lot of people don't realize. And that's just a basic hospital stay with a basic bed. We're not talking about ICU stay. We're not talking about operative costs. These are just basic, I'm staying in the hospital, this is how much it costs. So you can imagine, if we can shave a few of those days off, how we can make a huge financial impact. Next thing that's very significant is hospital-acquired infections. And that's obviously a hot topic for many reasons. It affects our reimbursement, but it also adds to our cost when we have excessive infections that are outside of the norm. It's, again, a big cost with $9.8 billion and SSIs contributing the greatest percent of that. So surgical site infections at 33.7%. So you can see how, if we can make a conscious effort to reduce things like surgical site infections, which we all want to do, but we have to figure out the best way to do that. So really our search here is for a system that reduces length of stay, reduces complications and SSIs, and then not only reduces them, the length of stay, but reduces the admissions, because it does us no good to send people home early and then have them come right back to the hospital. So those are our historical numbers that have really pushed us pre-COVID to really build a robust ERAS program here at Scripps. But then we have this other little thing that's happened over the past few years, which we're all well aware of, that's put an even more significant strain on our hospital systems. With COVID, hospitals nationwide will lose an estimated $54 billion in net income over the course of the year, even taking into account the significant aid that's been provided by the CARES Act. Estimates say that more than a third of U.S. hospitals will maintain negative operating margins through year's end. However, the uncertain trajectory of the Delta virus and Mu variants in the U.S. this fall could result in even greater losses. So again, these numbers are just not sustainable. We have to transition and we have to be proactive because these things are unchangeable and we have to change the things that we can change. Patients are also sicker, and sicker patients cost more money. Hospitals are seeing higher acuity inpatients. We have patients in the ICU for weeks and months on end on things like ECMO, which are beyond expensive. But, these are the operating costs that we need to take into consideration. And, these long lengths of stay are getting better as the surge decreases, but it's obviously going to continue to impact us. Higher expenses are rising across the board. Hospitals are facing increased cost of labor. We're at a point now where at Scripps, and I'm sure many other hospitals are experiencing this, that is now trickled down to the staffing issues, where we are having to make conscious decisions about which surgeries we do because it's putting so much of a strain on the system because of labor shortages, because of burnout from COVID. So these are all huge things that are impacting and continue to impact costs, PPE, and then factor in, as I put my value analysis hat on, factor in all the supply issues that we've run into, and that's just another stressor on the system. Some interesting visual of this is a graphical representation of hospital revenues starting in first quarter 2019, and you can see that dramatic dip with the recovery, admittedly, but these things are not going to happen quickly, and I think it's our responsibility to be as fiscally proactive as we can to really help in this recovery. This is a really interesting representation of recessions that have happened over the past 40 years, starting in the early 80s, and with our most recent recession, and its hospital revenue and how it was impacted. And you see, for the most part, hospitals have been pretty immune to recessions. But obviously, this most recent surge in COVID has directly impacted hospital revenues more than any previous recession. And again, we're seeing a light at the end of the tunnel, and there's signs of recovery, but we need to take it upon ourselves to really do as much as we can to help with this continued recovery and the continuation of this uptrend in revenue. So how do we do that? I mean, we know time and time again that protocols and standardization are great ways to save money. We see that with many other different kinds of hospital-acquired infections, UTIs and Foley management, central line management, and all the protocols that come along with managing those things. Well, if we talk about ERAS and we look at ERAS, we're really, in the most basic terms, protocolizing the things that we do around surgery. So as I'm sure you are all aware, ERAS stands for Enhanced Recovery After Surgery. But in reality, it's something that does not just happen after surgery. And actually, the more important parts happen before and in surgery, with the continuation of this after surgery. Historically, it's had a number of different names, and you may continue to hear some of these names: enhanced recovery pathways, or ERPs. The earliest description was a fast track protocol, but this was thought to bring some negative connotations in that we were trying to get patients out faster, even though that's part of what we were trying to do, but it was in a safe way, not just a fast way. But we eventually settled on ERAS, enhanced recovery after surgery. First described by a Danish surgeon, a Danish colorectal surgeon, in 2000 in his seminal paper in the Annals of Surgery. He looked at 60 patients, 60 of his own patients, where he established a very basic protocol based upon comparison to some of the protocols that we have today. But a protocol was established, and he saw it through with his 60 patients. And these were all open surgical procedures, open colectomies, 60 patients with an average length of stay of 2 days when he stuck to his protocol. And so that was mind-blowing, because open colorectal surgery in those days, this is sort of in the early phases of laparoscopy and minimally invasive surgery. But generally, those patients at best would be a week, 8 days, 10 days in the hospital. So to have an average or median length of stay of 2 days was unbelievable. In its most basic terms, ERAS is a multidisciplinary, evidence-based approach to decrease hospital stay, reduce cost, and increase patient satisfaction. So it really checks all the boxes. If we think back to when we were defining our problem, it really is the perfect solution to what we need, and especially now with the additional strains associated with COVID. So it's really a lot of what we currently do, but it's done. Much of what we currently do is done simply because that's the way we've always done it. But we really need to begin to question the old ways. Again, we can't just continue to do things because that's the way we've always done it, especially with these initial more recent stressors on the system. So what is an enhanced recovery pathway? This is kind of a nice general overview. It is a standardization. It is a protocol. It decreases stress. It decreases organ dysfunction, and it improves post-op recovery. Many of the programs focus on patient education, and I might argue that this is one of the more important aspects of any ERAS program. Pain control, optimizing pain control, fluid balance, early nutrition, and early ambulation, all undeniable parts of any ERAS program. There's a lot of parts that can be customized to your hospital system and what works best for you. But I would say that these points are some of those kind of undeniable things that define ERAS. It improves outcome with increased cardiopulmonary gut function, increased patient satisfaction, decreased fatigue, morbidity, decreased hospital costs and length of stay. And again, you'll see that this was originally all created in the colorectal surgical population, but that's really moved on. And some may argue that there is no surgery that ERAS cannot be applied to. Obviously, it's going to have its own little unique points within each surgical service line, but the benefits still continue regardless. So this is again kind of a nice graphical figure representation of how we break down ERAS and what are some of the more important points within each part. So it's the preoperative or pre-surgical evaluation. Again, patient education and counseling is huge. Sitting down with your surgeon or nurse and having this discussion. Some change in the ways that we feed patients preoperatively and prepare them for surgery. During surgery, we want to be mindful of our fluid use and how that can impact patient recovery. Be careful with pain medications, because obviously, especially in a colorectal world, that can have a huge impact on how patients recover. Use of minimally invasive surgery is obviously important. Those are well-established benefits, and if we can leverage those in addition to ERAS protocols, I'll show later on some studies that show those dramatic improvements. Post-surgery, again, early mobilization, early removal of drains and tubes, transition away from IV medications, and early enteral feeding, allowing people to eat. That's a big kind of change in culture. And ultimately, this leads to, increased patient satisfaction, decreased complications, decreased length of stay, and most importantly, or in regards to this talk, improved use of hospital resources. So let's just touch upon each of those phases. Again, I'm going to give you sort of some of the bigger points that define ERAS. We're not going to go through every one of these, but I do want to go through a few of them, tell you how we do it here, and kind of some of the science behind these seemingly simple interventions. So patient education and setting of expectations, I've said that a number of times already, and we'll continue to talk about that and how important that is. Exercise and the concept of prehabilitation. In other words, it's easy to imagine how someone who's healthier coming into a surgery is going to do much better after a surgery. So, we need to keep that in mind and take advantage of that and leverage that. Obvious things like smoking cessation, but again, communicating to the patient and letting them know that even in the short term, there's huge benefits to that. Modern fasting guidelines, and we'll talk a little bit more detail about that, and also carb loading, which is one of the things that is somewhat unique to ERAS. So patient education and setting expectations. And again, in my opinion, I would argue that this is one of the most important parts of any ERAS program. It provides patients with the tools to manage the stress of the surgery and become partners in their own recovery. And you're always going to get better cooperation when the patient feels included and they're partners in their recovery. I'll tell you, from having this conversation with every surgical patient, I can almost promise you that they're expecting something different than what you're going to be telling them based on previous personal or family experience. So it's really important to set appropriate expectations surrounding, feeding, activity, pain, all of these things. They're going to have a much different idea of how this is going to happen. They're going to get a lot from this conversation, but a lot's coming at them. We believe here at Scripps that it's really important to send them with a good reference that they can refer back to, that's written in plain language and can further facilitate that understanding at a later time. Again, pictures and text. We're actually working on developing an app where patients can that's connected to our electronic medical record, and they can get some of this information linked in their app and refer back to later on, and we'll give them real-time reminders on their phone as their surgery approaches. So this is our basic enhanced recovery after surgery brochure that we give with every patient. This is colorectal specific, but for each of the service lines that we've developed since, we've kind of used this as our basic format and done some editing. So again, that's again plain language, and it's a great reference for people to go back to. Modern fasting guidelines, and this is, I think, some a big change in terms of ERAS and how we do this. Basically, any lay person and most medical personnel, if you ask them about dietary restrictions before surgery, almost everyone is going to say NPO after midnight. That's what we've always heard along the way. I think that's the worst words that can be uttered in a hospital. You're starving a patient for no reason, and you're starting with a patient who you're making them more unhealthy than they need to be. Ultimately, the concern, mostly from anesthesia, was for aspiration of gastric contents during induction of anesthesia. Ironically, the literature supporting modern fasting guidelines comes out of the anesthesia literature, yet many anesthesiologists continue to stick to the old ways of NPO after midnight. There are good studies on gastric emptying studies that it's safe to consume solid food up to 8 hours prior to anesthesia and clear liquids up to 2 hours. This again goes back to evidence-based practice versus tradition and dogma, and these things are very hard to overcome when people have done it this way for a very long time. It leads to some of the most common complaints by the patient, being thirsty, hungry, and having headaches if they're coming in dehydrated. So already we're making the patients happier. Carb loading, this is a something very unique to ERAS. Again, it changes that overnight fasted state to a fed state, and that's a much better state to be coming into for a big major abdominal operation. In the fed state, there's the activation of insulin to 5 to 6 times the basal level, which in turn maximizes your glycogen stores, which is what your energy comes from. And then with those increased glycogen stores, you do better in the catabolic postoperative state. The fed state also decreases the degree of postoperative insulin resistance by as much as 50%. And this leads to less hyperglycemia and improved retention of protein in the postoperative period. Not all carb drinks are appropriate. There are certain drinks. A lot of people will give sports drinks. This isn't a sugar load. There are, specific drinks that are used for this. They need to be high in complex carbohydrates and hyperosmolar, and it increases those basal insulin levels and facilitates gastric emptying. There are packs available. As we started out early on in our program, we saw the benefit of these things, and we encouraged patients to buy them on their own. But as your program matures, the cost of supply should really be absorbed by administration. And these are minor compared to the savings you will get with a robust ERAS program. And they're available even in packs that can be delivered to patients' houses, which in the time of COVID, with less pre-surgical evaluation visits, is a really great option for patients to get the things that they really need and will benefit them with their surgery. So moving on to intraoperative, again, these are the major points. We're not going to cover all of them. IV fluid use is a big point. We'll touch upon that. Obviously, minimally invasive surgery, multimodal pain management, glucose control, normothermia, antiemetic prophylaxis, and regional anesthesia. So IV fluids, this sounds like pretty common sense, but the aim should really be to achieve zero fluid balance. So we don't want to overload, we don't want to underload, we want to give just the right amount. There's many theories on what's the best way to do that. Unfortunately, some of the old ways of following urine output and responses to blood pressure, you're already kind of behind by the time those end organ issues are happening. So there's arguments of goal-directed fluid therapy where and actually invasive or non-invasive monitoring devices are used, and fluid administration is based on real-time changes. But that's a lot, and that's obviously another cost. So really just the anesthesiologist being mindful. We like to limit fluid, especially in bowel surgery, because that can cause edema in the bowels and lead to significant postoperative complications, ileus, and slower recovery. Anesthesia, this is really an anesthesia thing, as a lot of the intra-op stuff is. I mean, from a surgery standpoint, we can control the surgery, but a lot of the other things that are happening to the patient are really in the hands of the anesthesiologist. So we really need to work well with them and make sure that they're aware of these issues and conscious of them. Minimally invasive surgery, again, in 2021, we should really all be doing this. Despite that, there are several areas where it is still underused, and there's still a wide range of results because of this. So we know, as compared to open surgery, that minimally invasive surgery is better for patients, but with the addition of ERAS to this, we can get even more dramatic results, as you can see in that data in terms of length of stay, and then and SSI rates as well. So we need to leverage the established gains of MIS and combine those with ERAS to really get the most beneficial outcomes. Role of the anesthesiologist, as I said, they're the most important player in limiting the stress response during surgery. We want to make sure, like some of the earlier things we touched upon, that these patients are in the fed state, be mindful of IV fluids, short-acting anesthetic agents with adjuncts to avoid, especially in bowel surgery, slowing down the bowels, antiemetic prophylaxis, maintenance of homeostasis, and then the role of regional anesthesia in the postoperative period is huge. Things like tap blocks that can really give patients pain relief and avoid any additional excessive pain medications. Post-op, again, we need to continue with multimodal analgesia, anti-ileus prophylaxis, examine the use of drains and tubes and catheters, which are going to keep the patients in bed and less mobile. We want early enteral nutrition, early ambulation, and again, continuing to include the patients in their care and recovery with daily care maps and predefined discharge criteria. Early nutrition and ambulation are key drivers of any enhanced recovery program. Long-term acceptance of the benefits of early ambulation have been established, but we continue to not do a great job, to be quite honest with you. It's easier to say the patient doesn't want to move, so I'm not going to move, but that's always part of setting expectations for me. So I'm having that conversation with patients in my office before the surgery, that this is part of the deal. Getting up and moving is important to your recovery. And so they need to be, given that they are active participants in their recovery, they need to abide by that. NPO after surgery, again, we still struggle with this. It's that surgical dogma. This is the way that I've always done it. How can I feed someone when I just operated on their bowels? Then the fact of the matter is their bowels will work quicker, and there'll be less complications if you feed them. If food is going to cause a complication, then you have not done a good surgery. I would argue that they should be getting clear liquids in the recovery room, and certainly food by post-op day one. Certainly some will fail, and that's always the question that everybody asks, but the benefits of success in the combination with other interventions far outweigh any risk. So how do we do this? I've just talked about a bunch of things that all are seemingly simple interventions, but it's not easy. It's not easy to get everyone to buy in. There's always going to be pushback with change. There's no cookie cutter approach. What works here at Scripps is probably not going to work at your hospital. And one of the most common questions I get is, well, what are the parts that work? I just want to do the stuff that works. And it's hard to know what works best. And time and time again, it's really been proven in the literature that establishing a protocol and sticking to a protocol is where you have the most success with any ERAS program. It is a multidisciplinary approach involving the patient. That's probably one of the bigger changes, but that does require participation of a whole bunch of different people. We can't just operate in our own little silo anymore. We need to push for these multidisciplinary approaches. We need administrative support, obviously the surgeon and obviously the anesthesiologist, but the nurses from a preoperative visit through pre-surgical evaluation, through the PACU, the floor, everybody needs to be on board with this to make it work. And as I said earlier, I was going to focus, not surprisingly, more on the colorectal stuff, given that that's my world. But this is applicable to a wide range of specialties, and we will show that here as we move forward. So getting finally to our implementation here at Scripps and our timeline. So we first went live with our first 2 protocols at the same time in March of 2017. Then that's not to say that's when we started ERAS. There was many people that were doing versions of ERAS certainly before that. But if we're talking about establishment of a formalized protocol, which, as I said, the literature shows that's where you get your most success, our formal vetted protocols were established first in March of 2017. We very soon added Gyn-Onc to colorectal and Gyn, and that was a pretty easy transition. All 3 of those are pretty similar in terms of the basic building blocks of the program. And then we moved on to bariatrics, which was, again, still within the general surgery realm. So a little bit of overlap, but certainly some very specific things. And we had to involve our surgeon champions and really develop that program with the help of the coordinators and the surgeons. And then finally, our last program that we instituted here at Scripps in October of last year was cardiac. And that was a very long process with a lot of work involving a lot of different service lines. You're talking about multidisciplinary teams, and now you're dealing with not only the cardiothoracic surgeons, but the cardiologists, the ICU nurses, and everything that's involved with those cardiac programs. We leveraged a lot of support and help from programs who had already established a cardiac program, and I would strongly encourage anyone who's thinking of doing that to do the same, whether it be us or some of the other programs around the country. So let's get into some of the data. We'll start with colorectal. Again, that was our earliest established program. And we look at enrollment, and I think this is important to know, because if we're not doing it on the right patients, it's not going to work. And when you first start, it's really hard to sell your program, and you're going to get a lot more pushback. But as the data rolls in, more and more people will begin to participate and see the benefits of the program. I think many programs, if they're hovering around 80%, that's a pretty good number. I think, we still have some room for improvement. There's been some ups and downs. Some of that is probably related to COVID. But the great thing is that despite maybe room for a little bit of improvement in terms of our overall participation, we've continued to maintain our very significant improvements in length of stay, SSIs per case, and readmission. If you look at the top graph, that shows our historical data. In the left bar, and that's from 6 months prior to institution of our program. with case matched patients and showing their average length of stay. We'll call it 8 days. And then ever since, we've basically cut our length of stay in half. So if we go back to that original financial discussion about what it costs for a day in the hospital, we're making a pretty big impact on our healthcare system just in this metric alone. And then you look at some of the other high cost metrics like surgical site infection, and you can see there's always going to be ups and downs, but overall we've trended in the right direction, and that continues to get better as the program matures. Readmissions, again, there's ups and downs, but I think and maybe some room for improvement here, but I think overall we've done a pretty good job. So moving on to GYN, this is a program that's been probably not our most successful, and it's really a numbers thing. We have a significant number of gynecologists who are coming from multiple areas, multiple hospitals, private practice, hospital employed, and we need to own this and do a better job of educating those physicians in terms of what they should be doing. And I think, we're getting there. Most recently, this year, even with COVID, we've continued to get the word out, and this is our results in terms of those same metrics: length of stay, SSI, and readmissions. Again, you can see the appropriate trend. A hysterectomy is not one that had a huge length of stay to begin with. So our gains here are more, not quite as significant, but still any little bit helps. SSIs are huge, and we've made after an initial surge, we made a pretty significant impact in SSIs and readmissions as well. So our GYN-ONC outcomes, again, our participation slides, you can see much better participation here because it's a much smaller group of physicians that we're targeting. We have a total of 5 GYN-ONC physicians here, so you can imagine that's a whole lot easier than the number of regular gynecologists who we're targeting, and we've been able to get them to participate in a pretty meaningful way, and that showed some great results: length of stay, SSI, and readmissions, especially compared to the baseline data. Bariatrics, again, this was a bit more of a challenge in that we kind of went outside of our initial established protocols, and the initial uptrend in participation, and we're seeing that even more and more in recent months. And you can see they had a great length of stay. It's another one of those where you're not going to make a huge impact in length of stay, but any little bit's going to help. Even if it's fractional in terms of the length of stay. Where the impacts are really in bariatrics, and the surgeons were very clear with this from the get-go, was going to be SSIs and readmissions. And I think that we will, again, the ups and downs in readmissions, but we will continue to push that program. And overall, I think when we look at the cost, which we will in a little bit, the results are more dramatic than they may appear from this data. And then finally, cardiac. This is a pretty impressive participation, and that stems from the fact that there's a lot of mid-level providers who have really bought into this program, and they are the ones that are responsible for all the preoperative and postoperative orders. So when it's coming from an isolated area, it's easy to get really good buy-in. And then we did have our little dip in May, but that was related to a cyber attack that we had here at Scripps, which severely impacted our ability to do anything. But you can see it went right back up in June. Now we're collecting. This is not by quarter, as you can see, because this program really just started. And so we've really gotten our first 6-ish months of data. There are some delays and lags in terms of the SSI data and readmissions. And there's a sort of a 90-day period where those SSIs can be reported. So it's not exactly 6 months, but this is, again, some pretty decent data, I would say, for a new program in its infancy. Length of stay, again, did not change dramatically, but it's where that length of stay is happening. Patients are getting out of the ICU much quicker. And again, moving from the more expensive bed to the less expensive bed is obviously going to have some significant cost savings, even though the overall length of stay is pretty much the same. SSIs have been good still, and readmissions, again, probably where they've made some of their biggest impacts financially. So this is our overall FY 2021 savings based on service line and then total. And you can see in a time where finances are tight, we've produced a pretty significant cost savings for the hospital. And this slide alone can really provide the support that you would need to have a continued ERAS program with continued support and a continued push to go and spread to even more service lines. So the take-home message is that, we've gotten really good at what we do. And that, it's hard to say we need to change, but despite this, some things have happened around us. And if we're not pivoting and making the changes that need to be done, the fear is that the system will fail, especially with the big hits that we've taken with COVID. With the introduction of some relatively simple evidence-based practices, we can begin to change this trajectory. We can foster an interdisciplinary collaboration and culture. We can decrease hospital stay by improving care organization and decreasing morbidity. We can reduce cost and improve the value of surgical care for our patients, which is essential. And all of this adds undeniable value to the health system, especially in our post-COVID world. So these things, there's plenty of resources out there. Obviously, I'd be more than happy to answer any questions that anybody may have. We'll have some time for questions here at the end, but you can always reach me at my email address. And we don't need to reinvent the wheel here. A lot of these protocols have already been established nationally, and you can utilize the information that's out there. You're going to have to, tweak it a little bit to make it work within your hospital system, but use the resources that are out there and don't reinvent the wheel. So with that, I'll pause for any questions, and that's the end of our slide portion of the presentation.
Thank you, Dr. Biermeister, for your presentation. I'd like to remind the audience that we do have about 10 minutes to take audience questions. So would like to remind you to put your questions in the chat section on your screen, and we'll get to those as soon as we can. We'll start with our first question for you, Dr. Biermeister. How has COVID-19, has COVID-19 had any impact on protocol performance across service lines?
Yeah, well, thank you, Carrie. I think, undoubtedly it would, there's no doubt, that there's certainly been an impact. I mean, throughout the COVID surge, we've had to really cut back on our operating. And I did touch base on the staffing issues that we're currently having. So I think for us, because we had already established most of our protocols, it was there to just pick up once we were able to pick up the volume again. But certainly if you were at a point in your ERAS development where you hadn't had all of those protocols established, I think it would be more of a significant hit on what you were doing. But certainly, yeah, I mean, it's undeniable that the volume decreased. So, the savings and the impact are going to decrease. But if you're positioned in a way where these protocols are in place, the assumption is that as we continue to recover, we'll continue to see these favorable numbers again.
Okay, thank you for that. The next question coming in, what would you say the downsides are of implementing ERAS protocols?
Well, I mean, I think the short-term downsides are going to be that nobody likes change. Certainly surgeons don't like change. And we do things, again, because of the way that we've always done them. So certain people will just be more willing to change, recognizing the immediate benefits of both the system and their patients. Others are going to be, and understandably so, these changes can have big impact on our patients and how they recover. And, some are going to be unwilling to just buy in because they see that it's worked somewhere else. So in those situations, I think, this is really where the auditing of the data becomes really important, and showing people how this works, not somewhere else, but how it works in your system and in like for like patients, where they're seeing that the patients are happier, they're recovering better. They're moving out of the hospital quicker. There's less readmissions. There's less SSIs, and that's going to get a whole new subset of people to buy in. And then, to be quite honest with you, there's going to probably be that 15 to 20% that just are going to continue to do things the way they do them because that's the way they've always done them. It's not to say that they're getting bad results, but I think we just need to strive always for better results. And that's why I had mentioned when I started going through our participation numbers, which I think is a great thing to track, is that if you're getting around 80%, I think you're pretty much where you need to be.
Very good. Moving on to our next question. Seeing the cost savings is great. Are there upfront, are there any costs associated with executing ERAS protocols?
Yeah, I mean, certainly any change is going to come with cost. I mean, there's the financial cost of things, which there are some. We touched upon packs and some of the supplies that are associated with establishing protocols and getting the patients the things that they need preoperatively, especially. And then there's things that it's a little harder to put a number on, in that this is going to take some time and commitment from a lot of individuals. And certainly that is a cost, and that's a cost that is not insignificant. But I think knowing where you can get with these protocols, I think the definable financial costs are going to be a wash. I mean, and that's something that I think most places that have established ERAS protocols, their administration over time, if not right away, have been very receptive in picking up those costs for the patients. But the cost of time and those things may not be as recoverable or easily recoverable on paper. But I think when you see how much better patients are doing and how much better the system is doing, that's again, it's a reasonable commitment, I think, to get much better outcomes.
Good to hear. Did COVID-19 have any impact on how you executed your protocols or protocols for particular service lines?
Yeah, I mean, I think it kind of goes back to the first question, and that certainly we saw the dips when everybody else saw them. I think certain service lines that tend to be more elective in nature, like maybe the gynecology people, they're going to take more of a hit because those cases are going to be harder to get on. But again, I think we were lucky enough to, have these protocols established. Now we wanted to continue to spread to other service lines. And as you can see, I won't say we've done nothing, but, we haven't really been able to introduce any new protocols since about a year ago when we phased in our cardiac program, and I would have to say that that's a direct result of COVID and what's been happening here over the past year. But we have plans to continue to push into different service lines, and those are our FY 2022 goals for sure.
Mm-hmm. For hospitals that saw delays in implementing protocols during COVID-19, what recommendations would you have on re-engaging?
Well, I think, understanding that this is going to have significant financial benefits to your hospital, engaging administration if you haven't already done that to get them on board. I think if it's not already established at your program, to understand that there's going to be some undeniable gains here. Again, it's certainly going to take some work, and having the right people involved is important in pushing these protocols. I might argue that having a small number of people, the more cooks you get in the kitchen, the more opinions you get, and opinions are good. And certainly it's something that you need to listen to colleagues and other people involved. But, if you're really talking about establishment of your protocols, I think having a small group of people with a vested interest in developing these protocols is going to be important.
Okay. Is there a particular threshold for performance or benchmark that you're following?
I mean, I think what we look at, and again, it's going to vary from hospital to hospital. The numbers that I put up are the participation rates. It's one thing to establish these protocols, but knowing who's doing them and how many people are doing them, and in knowing that, then you can know where to focus your energy, because you don't just establish these protocols and then that's it. There's the constant auditing, there's the reevaluation and going back and tweaking the programs. Just because you think that what you do is going to work doesn't mean it's necessarily going to work. So you need that's ongoing work. So whatever benchmarks you establish, I think we found that the most value is in the participation rates, because we can see that, look at, this is where we need to focus our energy. We need to, get out to the offices, have them, let us know, is there anything we can do to make this easier for you? I mean, we have standardized order sets, we have all these things, but there's also those order sets that existed pre-ERAS. And if people are just set in their ways and not aware of what's going on, especially if they're not as intimately involved in the on-campus activities with more outpatient care, then it's you can understand how that would definitely impact your program.
Wonderful. Great insight. Thank you so much for sharing that. Before we go, we do want to bring up a poll. Wanted to know from the audience if you would like to be contacted by Cardinal Health to learn more about their Enhanced Recovery Pack solution. Please let us know and take that poll, and we'll be in contact. And today, you can earn 1 CE by completing the CE quiz that is on the screen there. And I would like to thank you, Dr. Biermeister, for your presentation and your questions today, and thank our audience for listening. We are going to take a 15-minute break, and our next session starts in about 15 minutes for the inclusive OR. And thank you once again for joining us. Thank you to Cardinal Health for sponsoring. Have a wonderful day.
Thanks, Carrie.
Thank you.